Good afternoon and welcome to West Berkshire Health Scrutiny Committee. I'm Councillor Rolls, Chairman of the committee. I'm supported by Councillor Alan Macro as Vice Chairman. Other members of the committee in the Council chamber this afternoon are Councillors Jeff Beck, Tony Linden and Andy Moore. Councillor Graham Bridgman is also present on Zoom as Executive Portfolio Holder for Health and Wellbeing. Councillor officers and external partners present to advise and support the meeting are Sarah Rayfield, Acting Consultant in Public Health, Andrew Sharp, Chief Executive from Health Watch, West Berkshire, and Gordon Oliver is the clerk for the meeting. The meeting is also being live streamed via YouTube and Melanie Booth is the Zoom host. During the meeting, I would ask that everyone wishing to speak to raise their Zoom hands. All voting will be done by an actual show of hands. Does anybody have any questions before we start the meeting? Okay, thank you. So agenda item 1, apologies for absence. Mr. Oliver, do we have any apologies for absence?
We haven't received any in advance of the meeting, Chairman.
Thank you. Moving on to minutes. Can I confirm if the minutes of the last meeting held on the 4th of May are approved as a true and correct record of the meeting? I remind members that this was just to elect chairman and vice chairman. Councillor. Thank you, Councillor Beck, as a proposer. Can I have a seconder?
I'll second it, Chairman.
Okay, thank you. That's Councillor Linden seconding. Can we have a vote in favour? Thank you. All in favour. Moving on to agenda item number 3, declarations of interest. Can I ask members if they have any declarations of interest relating to any items on the agenda?
Councillor Moore.
I
would just like to declare, I think I'm on, am I? Yeah. I'm an NHS volunteer. That probably ought to stand as a standing item of interest, register of interest for this committee.
Thank you very much. Okay, moving on to petitions. Can I ask Mr. Oliver, have we received any petitions? Oh, sorry.
Andrew Sharp had his hand up.
Yeah, apologies. I didn't see Andrew.
Sorry, I just thought again as a standing declaration of interest. I'm currently the chair of trustees of the West Berks Rapid Response Cars. So ambulance response times may come up at some point. So rather than just do it for agenda items, it might be best to hold that as a standing item, if that's okay. Thank you.
Thank you very much. Okay, just moving on to petitions. Can I ask Mr. Oliver if we have received any petitions?
We have not received any petitions, Chairman.
Thank you very much. Okay, agenda item 5, terms of reference. As this is our first Health Scrutiny Committee, I think it's important that we just set out and reference and explain our terms of reference, which were agreed when the committee was first established at full council on the 4th of May 2021. The terms of reference explain that the role of the committee is to undertake scrutiny of public health and NHS services in West Berkshire. Scrutiny of social care services is to remain with the Overview and Scrutiny Management Commission. Core functions of the committee include, as a reminder, scrutinising any matter relating to the planning, provision and operation of health services, seeking and challenging information about the quality and performance of these services, responding to consultations on proposals for substantial variations or developments in health services. Just wanted to point out that we will be developing a joint protocol that will help us reach a view on whether proposals constitute substantial variations or substantial development. We're getting a bit of feedback there. Okay, and this will be included on the work programme to be discussed later in the meeting. Terms of reference acknowledge the powers of the committee to refer matters to the Secretary of State where we are unable to reach agreement with an NHS body or provider. However, just to point out that this is very much a last resource. And Health Watch West Berkshire is the local consumer champion for health and care services, and we will be having a standard agenda item on the agenda for them to provide updates to the committee, and we very much welcome Andrew Sharp here today. The committee has responsibility for setting its own work programme and is able to set up task and finish groups to undertake in-depth reviews on particular issues or services. However, it will report to OSMC so they have oversight of its activities. Since this is a new committee, we do not yet have dates for future meetings, as you'll see on the work programme. It has been suggested that we meet quarterly in advance of OSMC meetings, with additional meetings convened to deal with urgent matters and consultations as they arise. Sorry, Graham, can I just say one or two more words and then I'll invite you? Yeah. The terms of reference also set out the membership of the committee, including provision for co-option of non-voting members to assist us with reviews. And finally, I just wanted to point out before I take questions, where NHS bodies consult on matters that cross local authority boundaries, we are required to set up joint committees. And where this happens, West Berkshire Council representation will be joined from this committee. Okay, has anybody got any questions? We've got Graham first. Graham, sorry, Councillor Bridgman first.
Thank you, Chairman. From the floor, as it were, I simply wanted to reflect, and this is not with my portfolio hat on, but with my Constitution Task Group hat on, and Councillor Moore will perhaps know where I'm coming from. I have said in a number of situations that we are working our way down through, as it were, the terms of reference for all committees. At the moment, we're working on appendices to the bit of the Constitution that deals with committee and council meetings. And the committees of council. And so this document will eventually morph into an appendix to that part of the Constitution. Clearly, some things that are in the terms of reference are actually already dealt with under the Constitution. So, for example, convening an extraordinary meeting, there's a whole process.
Graham, sorry, Councillor Bridgman, we've slightly lost your sound.
To apologise. Can you hear me now?
Yes.
Right. Well, please wave at me if that. I don't know why. Is all I can say.
We can hear you.
All I'm saying is that this will morph into another document, and some of the aspects that are currently in there are in fact already covered by the Constitution. I was giving the example of calling an extraordinary meeting. There's a whole process in the Constitution for extraordinary meetings of committees to be called, for example. So that's it. So you're aware of where we're going to generally in the Constitution with this type of document. Thank you, Chairman.
Thank you. Councillor Linden.
Thanks, Chairman. On the membership and quorum, I think with a committee of 5, it makes sense to have a quorum of 3 rather than 4, because it is quite tight. And also some people may want to attend remotely indicative meetings or whatever, especially if they've got a shield or whatever for COVID. So I just think we need to look again at that. And also maybe a suggestion that we look again at our numbers. Maybe we go from, say, 5 to 7 members. It might, because obviously there's a lot of work on. And I think it makes sense to see if we can get some more members on.
Thank you. Councillor Moore. Councillor Moore.
Thank you, Chair. Press one button, press another button. Thank you. It's slightly, possibly arcane point of English, but I just noticed in rereading these for this meeting, in function of the committee paragraph 1, we've got the word ensure at the end of the second line. Now, this maybe comes from my years as a regulator, in which we were quite clear that a regulator or indeed a scrutiny committee doesn't have the powers to ensure to do something, but its function is to assure by scrutinising and etc. And I just wonder whether in a review of these, whenever we do that, we might consider the word assure there rather than ensure. As far as I know, the committee is not empowered to actually affect any treatment in the NHS, for example, and that's probably all to the good.
Yeah, thank you. Can I just point out that any changes to the terms of reference must actually be agreed at full council as well? Andrew Sharp.
Thank you, Chair. I've just got a question, and this is in relation to our brave new world of integration of health and social care. That it obviously states that social care scrutiny will remain with the existing Oversight and Scrutiny Committee. I wonder if any thought or actions are already in process for jointly commissioned services between adult social care and health. So when we're talking about things like discharge from hospitals and things like this, and presumably in future there may be some more. So it's more a question of, are the procedures and processes for dealing with that sort of thing, or would both committees do it? So it's one of those sort of not knowing council procedures as well as everyone else. I wonder if someone could offer an opinion. Thanks.
Thank you. Mr. Oliver, is there any comment on that?
I think this is possibly a grey area. I was hoping Andy Sharp would actually be on the call because we've had similar issues and discussions about the review that the CCG is doing on continuing healthcare and which side of the fence that should lie in terms of whether it should be OSMC or Health Scrutiny Committee. So I think where these sort of issues come up, we have to look at who's taking the lead on this, whether it is the CCG or the local authorities through their adult social care function, and whoever is that lead organisation, we would treat that as being the direction in which we point scrutiny.
Thank you. Councillor Bridgman.
Yeah, if I start, I wasn't asking to speak on that point, but just to reflect on that, I think that's absolutely right. I mean, to some extent, it may be that this committee and OV and Scrutiny wish to appoint a joint working group, subcommittee, whatever, in order to do that piece of work. But I think it's going to be horses for courses as they come up. And it very much, I suspect, depends on where the real power lies. Is it really the CCG that's doing this thing and adult social care of the client, or is it, whatever it might be, in order to determine who should scrutinise? That wasn't the reason I raised my hand, though, Chairman. I just wanted to come back on Councillor Linden's point about quorum, just to reflect that the Constitution is clear. The quorum for a committee of council, which this is 1/3 or 4, whichever is the lesser. So, so therefore, you cannot get away from less than 4 unless you change that bit of the Constitution.
Thank you. Thank you for that, Councillor Bridgman. Any more questions on the terms of reference? Okay. Moving on to agenda item 6, which is the Joint Health and Wellbeing Strategy. And I'd like to invite Sarah Rayfield to present the report.
Thank you, Chair. I have a presentation to share. I shall just share my screen. That's coming up. And thank you for the opportunity to bring the strategy to the
Can you hear? Can everybody hear okay? No. Is your...
Yes, certainly.
You can hear it.
I'll speak louder in the room.
Thank you.
Thank you. Issue here, but thank you for the opportunity to bring the strategy to the committee this afternoon. So I'd like to start with just going through the process by which the strategy has been developed. So it started back in April of 2019, where a decision was taken by the 3 chairs of the Health and Wellbeing Boards for Reading, Wokingham and West Berkshire. But in terms of the development of the strategy, we started work in March of 2020. And that began by evaluating the current strategies and looking for evidence of impact, and then using that work to then identify what were the ongoing needs of our populations across Berkshire West. We did this by looking at the data that was available, but also through discussion with different stakeholders and key partners and organisations that were working across the area. All of that discussion and work led to a long list of priorities, and this was about 30 in total. We then used a series of online workshops in order to refine these priorities down to our final long list of 11. And then in November of last year, we then went out for a public engagement piece in order to further refine those into our final 5. I'll come on to talk about the public engagement in a little bit more detail in a moment. We then had our first draft of the strategy was finished by April, and then we've more recently gone out for a 6-week period of public consultation on the final draft strategy. And then that will lead us to the final strategy itself. Just to touch on the population need for West Berkshire. So we have just under 160,000 people in our area, about 20% of whom are aged over 65 and approximately 5% are ethnically diverse. Just over half of people in our area are in very good health. And while 3/4 of children achieve a good level of development in the early years, only 40% of those children who are on free school meals achieve the same level of development. We also have rising rates of overweight and obesity as people age, with 20% of reception-age children fit in this category, 30% of children in year 6 and 60% of adults. We have a gap in employment rate between those with a learning disability and the overall employment rate. And for us, that is higher at 78% compared to 71% in England. And our estimated dementia diagnosis rate is lower than the England average. In terms of mortality rate from causes considered to be preventable, that is higher in West Berkshire than for both the England and South East average. So in terms of the public engagement to help us develop this strategy, this was always intended to be at the heart of the development of the strategy. And we co-produced and delivered this through a consultation, engagement, task and finish group, which had a number of members from different organisations such as Healthwatch, West Berkshire, Community United West Berkshire, Involve Wokingham, Reading Voluntary Action, members of the public health teams across the 3 local authorities as well. The engagement was centred around an online survey and then 18 focus groups, which were specifically held with underrepresented groups and those who have been deemed to be less likely to engage in such consultations previously. The online survey had just under 4,000 responses, 1,200 of which were from West Berkshire. We were disseminating the survey through local organisations and town and parish councils, and we tried to encourage different organisations to engage with the survey, with the strategy development through this route as well. The focus groups were held by either the strategy group itself or by other organisations such as Healthwatch West Berkshire. And these were held with the following groups of young carers and unpaid carers, older people, ethnic diverse communities, those with learning disabilities, young people and parents and maternity. I've included some examples of comments from West Berkshire residents throughout this engagement process. And this is just a snapshot of comments. There's further detail is within the public engagement report, which accompanied the paper. But there were comments around better communication and support for parents of children with mental health difficulties, a suggestion that the authority needed to bring together the educational needs and long-term well-being of young people, comments around financial support and supporting people and families that work but still struggle to pay household bills, various comments around coordination between social services and NHS, especially focusing on specific groups, for example, elderly and vulnerable people. Dementia featured quite heavily in the consultation and engagement, with particular comments saying it impacts on so many people and families, but also requires input from so many agencies. And then there were a number of comments around different groups, and in particular, acknowledging that minority groups are less likely to trust public services. And so more work is needed to engage religious, faith and minority group leaders in order to promote our health and wellbeing services. We used this public engagement and all that we heard from our residents through both the online survey and the focus groups in order to refine and finalise our priorities. So we went out with the 11 and ended up with our final 5. And these are as follows. So to reduce the differences in health between different groups of people, to support individuals at high risk of bad health outcomes to live healthy lives, to help families and children in early years, to promote good mental health and wellbeing for all children and young people, and to promote good mental health and wellbeing for all adults. The strategy is underpinned by 8 principles through which we hope to achieve the priorities as stated. So at first, recovery from COVID-19. We want to continue the engagement work that we've started through the development of this strategy and put ongoing engagement really at the heart of implementing the strategy. We recognise that prevention and early intervention is really key, but also working with communities and individuals, focusing on empowerment and self-care. Digital enablement has been really key, particularly during COVID-19, but acknowledging that not everybody has access to digital services in the same way. And then finally, social cohesion, integration, and then continuous learning. This strategy is to be in place for the next 10 years, but we acknowledge that we don't know everything that we will need to know over the next 10 years. So it's important that we continually learn and adjust as we need to over the next few years. So the draft strategy was finished, well, the first draft of the strategy was finished in April, and we've just recently completed an online public consultation for 6 weeks. So that was from the 24th of June to the 4th of August. This was undertaken in West Berkshire and Reading, and it was essentially promoted by the communications team for West Berkshire and Reading, but also disseminated by the members of the Consultation and Engagement Task Force. In total, we've had 162 responses to this online consultation. The vast majority were from West Berkshire, and 26% from Reading and 7% from other local authorities. Again, the majority were answering as an individual. However, 12% did state that they were responding on behalf of an organisation. And this included Together for Mental Wellbeing, Talkback, the Alzheimer's Society, Connecting Communities in Berkshire, Bucklebury Parish Council, A2 Dominion Housing Group, and Reading Deaf Centre as well. We're still continuing to analyse the results of this public consultation, but I've just got some early findings to share with you today. So the main crux of this consultation was asking people how they felt about the priorities that we'd identified, those top 5, but also the objectives that we had specified as within each of those. So there was initial questions on, do you agree with this priority? Yes, no, or unsure. And as you can see within the orange bars on this chart, the vast majority of people did agree with the priorities that we had included. And in particular, for mental health and wellbeing for all adults, that was particularly high agreement. The blue bars show the percent agreement with the specific strategic objectives under each priority. And again, fairly high. We noted that under health, families and children in early years, this was a bit lower, but still 65% of those responding agreed with the objectives that we had set out. We did ask people what they, if they felt there was anything missing, but also if there was anything they wished to add under these specific objectives and for the priorities. And that's the consultation findings that we're really delving into at the moment. And in terms of some general themes from the free text comments, I would say there was generally an acknowledgement that the priorities within the strategy are sensible and important issues, and a general feeling that people fundamentally agreed with those that we had chosen. A number did comment on the fact that the priorities are quite interlinking and overlapping, which I think is something that we acknowledge ourselves. There were comments about the accessibility of the strategy, which is something we need to reflect on and look at, and in terms of the consultation and whether we managed to hear from everybody we would like to. I think there were a number of comments around the need to continually listen to and engage with the public themselves and the voluntary groups that work with them. And particularly, I know this has been quoted a lot, but the idea of nothing about us without us, and continuing to listen to the groups that we've specified within the strategy. Another theme was around the need to have a greater emphasis on the social determinants of health within the strategy, but also a number of comments around acknowledging that although there's a role within NHS and social care services, there's also an element of self-empowerment and self-management and people taking responsibility for their health themselves. Other things we will look to address was around the wording, a request for it to be more specific in parts. There was a number of questions around, will there be funding in order to implement this? And again, I would say one of the strongest themes that we found in the consultation was that we needed to now be specific about how we will deliver this plan and this strategy, and to provide a commitment beyond the words of the strategy and having measurable targets. And I think that brings me on nicely to the delivery plans, because that is exactly what we are in the process of developing as well. Although this strategy is shared across Berkshire West, each of the 3 local authorities are developing their own delivery and implementation plan for how the strategy will be delivered in their area. So for West Berkshire, we started this work with a Health and Wellbeing Board workshop on the 24th of June, where we took each of the 5 priorities under breakout rooms and really started that discussion about what do we need to do in order to achieve the objectives that we have within the strategy. We've now taken that initial discussion and are working with each of the health and wellbeing subgroups and key individuals to then further develop the action plans that will sit under this strategy. We're looking at actions at both the West Berkshire footprint, but also where it makes sense to do so, and there are clear benefits, those that need to be done at a Berkshire West level. The ICP is already using the priorities in order to help frame their future work. And we're looking at where we can work with the CCG in order to develop and deliver on some of these priorities. There's been an early meeting with the CCG, and there's a follow-up one in a couple of weeks' time as well. The delivery plan for West Berkshire will be essentially for the first 3 years of the strategy, but it will include a regular cycle of reviewing and refreshing the objectives within it. We are including indicators to ensure that we can measure our progress and targets to aim to achieve. And the plan is to take a draft delivery plan to the Health and Wellbeing Board in September. And I just thought it might be helpful to list the different groups that we're engaging with to develop each of the delivery plans. The majority of these are the current subgroups of the Health and Wellbeing Board, but then other key individuals and organisations that are relevant for each of these priorities. And then just to round up, so our key future milestones, as I mentioned, the public consultation closed last week on the 4th of August. We are now continuing to analyse the findings from that, revising the strategy in line with what we've heard, and we will produce the final version of the strategy by the 27th of August. The final strategy and accompanying draft delivery plan will go to the Health and Wellbeing Board in September. And then the plan is to have the final delivery plan signed off by the Health and Wellbeing Board, along with the governance arrangement to deliver it in December of this year. So thank you, but I'm happy to take any questions.
Thank you very much. Any questions? Councillor Moore.
Thank you, Chair. One just for the layman, the diagnosis rate for dementia. Could you just unpack that slightly? I'm just maybe is what generally is a diagnosis rate, but a bit it'd be helpful.
Yeah, I mean, I think essentially that measure is looking to ensure that we are identifying everybody that we can with dementia. And so I think that indicator is being used to kind of understand how well our pathways are working. So it's a tricky one to sort of get your head around sometimes, because you think, well, actually, ideally, we don't want high rates, but actually it's about identifying those people with it and how well we're managing to identify that, which is why we want it to be higher, to ensure that we're identifying people with dementia as early as we can in order to put that support in place for them and their.
So does that assume a sort of national rate of people with dementia, and that is then reflected in this area, and the people that you've diagnosed are a percentage of that? Is that how that works?
I think there's a national target at which you would, or rather there's, in terms of whether, it's all of our indicators, this comes up down to public health data. We have sort of green, amber and red. And so there's different levels at which you would be red, amber or green, depending on how high your diagnosis rate is. Yes, but I'm not sure off the top of my head exactly what those rates are and what we're aiming to be, but that's where it comes from.
I will have another one, but let somebody else go first.
Thank you. Councillor Macro.
Thank you. It's a question really of how that long list of 11 was derived. Bearing in mind, first of all, I think in the public consultation, 28% of people thought there ought to be other priorities in the list. And also, I noticed there's nothing there, particularly for services for older people and things like dementia, which we know is a major issue that's coming. So I just wondered exactly how we got that long, but 11 long list. and why some of these other things perhaps aren't there. Thank you.
Yeah, so the work that we did in order to get to the 11, we started by looking at the current strategies to say, well, where have we made a difference? Where are those gaps? We also contributed to that by speaking to different groups and stakeholders across the whole of Berkshire West, the 3 local authorities, sort of public health, education, housing, and different groups across that sort of work within and with our communities to sort of understand that narrative about what they felt our population need was. We then also looked at our data to understand our population need from a data point of view. And then we did what we called a what's missing exercise. So we kind of looked at all the data for the 3 areas, looked at anybody who was red on it in terms of the data indicators, so saying that they were an outlier. If an indicator was red for either at least one of the 3 local authorities or amber for all 3, then we kind of added it to the list, as it were. And all of that work and engagement work from a professional point of view gave us a really long list of over 30 priorities. Then last summer, we ran a series of stakeholder workshops where we invited members of the Health and Wellbeing Board and other key partners. And we essentially went through priority after priority and had a series of questions that we assessed each priority by, mostly around was this work being done somewhere else? Would it be duplication if we included it in the strategy? Was there a way in which we could work together as a system to address this? So those were the sorts of questions that we used. And through that series of narrowing it down, we got from our 30 to our 11. And then those 11 were what we then went out to the public and said, what do you think? Essentially, what would make a difference to your lives? And then we took the engagement findings from those 11 and all that focus groups and the survey to then refine down to our final 5. And I agree, we did have a reasonable percentage of people who said there was something missing. In general, they were things we had considered as part of that process. And I would also say that some of them were things that were included, but perhaps included in a wording in a different way, if that makes sense. So there were a lot of the suggestions we were like, well, those are in there, perhaps maybe not as explicitly as people would have liked. And I would say in terms of the dementia, so dementia fits under the second priority, which is around supporting people at higher risk of bad health outcomes to live healthy lives. And those living with dementia is explicitly mentioned as a group of which we wish to focus on, along with a number of other groups. So they fit under there. And that priority, they're the groups we're saying we're starting with, essentially. But we acknowledge that over the next 10 years, the groups who are at higher risk may change. And that's something that we will keep under regular review as to who are the groups we need to be concentrating on, and in order to improve the lives of our communities.
Councillor Moore, do you have another question?
Yeah, thank you. I think you said that after below the strategy, each local authority will do a delivery plan. What's now? Okay, the strategy is commonly agreed, so ought to be putting things in the same place. But what if there is a contention between the delivery plans of the 3 different local authorities? What's the mechanism for resolving any of those?
I think I would say that, so I think in terms of we're trying to have a shared sort of direction and vision with the shared strategy, but how each local authority chooses to implement it is going to be naturally quite different. And I think what we are doing, so I'm still leading on that process for each of the 3 areas, although it's being kind of created locally by the relevant teams for the other 2. So we're still working to coordinate that process to some degree, and we're looking at where there's which of those actions need to be done together. So there'll be some actions done locally and some actions done together, particularly anything around which would require working with the CCG, or actions that the CCG or ICP will take on ownership of. And so we will each reflect those within our delivery plans. I don't see that there would be contention between them, because we each have ownership of our separate delivery plans, and that's how it will be local. So we may choose to emphasise a particular part of it in the first 3 years, whereas Woking or Reading, for example, may choose to emphasise or focus on another area, and that's okay, because we've still got different actions or some actions that are across the whole, and we're still kind of having that coordination in terms of where we start off from, as it were.
Okay, thank you.
Councillor Bridgman.
Chairman, if I may, just to reflect on a few of the things that Sarah said and some of the questions. And apologies if this audio drops out, please just sort of wave at me, because I have no idea why that might happen. So I have said on a number of occasions, and I'll say it again, that it's all very well having a strategy. What matters is the delivery plan. So what are we doing? Who is doing it? How is it going to be done? And what parameters, KPIs, whatever, are we putting round success? Hang on, what is success in that particular area? And that is the work that's going on at the moment in order to sort out what the delivery plan looks like, and in particular, which bits of the system, and by that I mean the West Berkshire system, are going to be doing the work. But as Councillor Moore quite rightly anticipates, there may be, and indeed Sarah said this, there may be aspects of this common strategy that would be better at place level rather than at locality level. And that would be the same. If we can identify things which would be better handled at place, and whether that is 1, 2 or 3 places, given that we have 3 councils, and we also obviously have the other bits of the health system linking into this, and it's already been anticipated that the ICP is taking a look at what this strategy lays out, then that of itself will need a delivery plan and some KPIs. We'll need to know who is doing it, how they're doing it, where the money's coming from, and what the KPIs are. So things will naturally flow as to who is doing it, how it's being done, and what do we treat as success. So this is a work in progress, obviously, but I believe that we will be able to identify what we do, what others do, and how we get the system to work together as we need it to. Thank you, Chair.
Thank you, Councillor Bridgman. Andrew Sharp.
Thank you, Chair. I just wanted to highlight to the committee that this kind of exercise is incredibly challenging at the best of times. But when you throw a pandemic in, when you're talking about engaging with your entire population where you practically can't go anywhere to see anybody, I think all the partners, and especially public health, should be tremendously proud that they've managed to actually put together a pretty good engagement program with good uptake from all sorts of key groups to actually make sure we've actually captured something meaningful, where we have actually listened to the public, listened to what worries them, and delivered it into a strategy that we can hopefully get behind and go forward. It really was a really positive exercise in genuine co-production. And co-production, many people will tell you, is really how things should always be done. It's about doing things with people, not to them, in as many services as possible. So I did just want to remind everybody, there were some incredible challenges in just putting this together. So to actually bring this document here, so both the partners, the team who did it, and certainly Sarah herself, have done a tremendous job in doing that. And I think part of our job here as this board, and as many other boards across statutory services, is to make sure, as Councillor Bridgman says, we now deliver something, we deliver change, we deliver action, so that when we are talking about health inequity or health inequality, we've actually made a difference rather than just gone through an exercise. Hopefully with the integration agenda at the heart of all this, it should be easier, but this does give us a really good roadmap. Thank you.
Thank you. Councillor Moore.
Sorry, me again. Chair, I'm not quite sure, were you at this point going on to look at the strategy itself? We've had a presentation on the development of the strategy. I've got just one question on the detail of the strategy, if that's
absolutely. I mean, it's a general open forum for questions on the strategy, which I think was, summarised. Obviously, there was the delivery plan, which was the other piece of it. But absolutely, I'm inviting questions on the whole strategy and on the presentation.
Okay. Thank you. Can I have one then, please?
Yes.
It's a bit of just a deep dive in, but in terms of the principles and the digital enablement bit. Sorry, this is me speaking on behalf of my 93-year-old mother who doesn't. And therefore, in a sense, can, as it happens, rely on me and my wife, but others might not be able to do that. I quite liked it was clear that you recognised that not everybody was able to do that, but the solution seemed to be to give them more digital capability. And so my question really was: is it also recognised that there will be some people who just will not and cannot, and therefore will still need to be able to, go to the surgery and all that sort of thing? Thank you.
Yes, no, I mean, I would completely agree with that. I mean, I think we acknowledge that many things are moving more digital, and so we want to be able to support and encourage people who are able to do that. But as I think you quite rightly point out, that is never going to be everybody, and we would never want to exclude people from being able to access those services. So there will always have to be some level of provision for people to be able to access those services if they literally are not able to. But for those that we are able to support to become more digitally able, then I think that's an important thing.
Thank you. Councillor Linden.
Thank you, Chairman. Just following on from Councillor Moore, you raised a very important point. Because of COVID and changes that we've had to do in terms of precautions, we've got a huge backlog, and some I'm going to raise at the end. But in terms of waiting lists and people trying to connect digitally, I know now we can go into our doctor's surgeries without necessarily just go to make an appointment and things like that. But even if you are digitally aware, there are always things you don't want to do digitally and you still want to do on the phone. And I think we've got to recognise that. And there are issues that I like to raise, not only online, but also meeting people face to face. And it does work in terms of human interaction. We've got to take into account people who will not use technology. You don't have to be an 87-year-old. My mother's 87. Or Councillor Moore's mother who's 93. There's a lot of people who are not going to get involved digitally, and they're much younger than we are. So it is at a point that not everybody is going to be okay with it. We do need to encourage more people to use things digitally, but the personal touch does count, and we've got a lot of catch up to do, and hopefully the strategy realises that, hopefully, and takes into account. The strategy has to be live. We have to be able to adapt with changing circumstances and the recovery, and we've still got to live with COVID. So it's going to be challenging. Thank you, Chairman.
Thank you. Councillor Macro.
Thank you. I'm picking up on the same thing, actually. I remember reading a few months ago, I think it might have been Dr. Mark Porter in the Times, basically saying he can tell what's wrong with people about 30% of the time as they walk in the surgery before they've actually said anything, just by the way they're walking, the way they're holding themselves and so on. And the other thing is that when you meet face to face, you can watch body language and expressions and know whether the patient is actually understanding what's being said, or vice versa. And certainly with a telephone conversation, you don't get that, and it's very difficult, I think, with some of the video technologies as well, because the screens are small and so on. So I do think we do need to remember that there are great advantages in meeting in person. And one further thing, I think the last kind of 3 phone consultations my family have had, I think 2 of them resulted in a trip to the surgery. So, and then you think, well, you've gone through it 10 minutes on the phone, you go through another 15 minutes in the surgery. Have we actually saved the doctor any time at all? Okay.
Thank you. Any other questions? I had sort of a similar question along the lines of the digital enablement, but particularly around sort of deaf impairment as well, and the fact that it's taking into consideration the disabilities, not just the age, which many members have mentioned, but also the fact that there may be some sort of ongoing training to get people up to speed. So that was just more of a point. But I also just wanted to pick up on Andrew Sharp's point about the enormous effort that's gone into working together in challenging times, and I think we should acknowledge that. I also, and I thank Sarah for her work as well. I actually think as well that it's not only that, it's about, when I first read the strategy, it was about putting the voice of the public at the centre of it and our residents. And I think that really came across in terms of the engagement, the lengths of the engagement. It wasn't just, there was various levels of that with the focus groups, with the online, and forgive me, I'm not very good on whether 3,967 is a good engagement, but that sounds pretty high to me. So I think we should be quite, quite proud of the fact that we've actually sort of done that and done that very thoroughly. So that was the only comments I was going to make. Councillor Mack, you still have your hand up. That's not a further question. Any other questions from the virtual floor anywhere? No? Great. Well, thank you very much. I think the recommendation was to review the content of the draft health and wellbeing strategy and to provide comments, which I think we've done. Members can endorse the strategy as it is or recommend changes. So I seek guidance from Mr. Oliver on.
We don't need to vote, Chairman. It's just for the Sarah to take on board comments made by.
Thank you. Hopefully that's been helpful. Okay, thank you. Moving on to agenda item number 7, Health Watch report. I'd like to invite Andrew Sharp to report on Health Watch's current activities and to present its annual report. The floor is yours, Andrew.
Thank you, Chair. I haven't got a presentation because the report really sums up our year, but I think I'd like to begin with a very, very brief description of what Health Watch does around the country. Health Watch nationally came into existence in 2013 with the new Health and Social Care Act, and there's basically a Health Watch in every local authority area across the country with the same job, which is really to represent the people, to be the people's champion, to take views, themes, experiences, learnings back to the people who put services together, hopefully with a view that good practice is recognised and repeated everywhere, and when things don't go quite so well, there's some introspection as to why they aren't working quite so well. We've got 2 statutory powers. One is a thing called Enter and View, where we are allowed to attend any health or social care service that's funded publicly, and unlike the Care Quality Commission, who will very much go through how the service should be run from a process point of view, we very much want to talk to the families, the people using the service, to find out what their experiences are. So you can probably see in a pandemic, there's going to be some limitations with certainly the Enter and View, which we clearly found, although to the great amazement of many, in fact, including Health Watch England, we still managed to actually get out and visit some care homes late December with an incredible amount of PPE, risk assessments, and what have you, to actually get in to talk to residents and their families about their experiences. And again, I'd just like to say a huge thanks to our team, our volunteers, our board, who make things like that possible. And the second power we have is the power of response. So while the first one was somewhat muted this year, because for a great deal of the time period the report covers, we couldn't actually go anywhere or places were locked down, or it wasn't safe for us to actually go and talk to patients directly. So we had to sort of repurpose, which is what we did. We used to do approximately one newsletter a month, and very quickly it became clear that there was so much information coming out around the COVID pandemic. We actually ended up last year doing 116 newsletters, and sometimes they were daily and sometimes they were even twice daily as information changed. So in repurposing what we did, it became clear to us that one of the key functions we actually fulfilled was letting the public know what was happening with services and how they were changing, and equally actually letting the service providers know what the public were experiencing because of some of those changes in service. So hopefully that's reflected in the annual report. But I think one of the key things that sometimes is overlooked, because people often sort of talk about, well, how many responses or how many people got in touch with you about things, is Healthwatch England did some work some years ago, and they basically found out that only 1 person in 100 actually complains. So people will quite happily grumble to their friends and their family that something wasn't very good, but it won't necessarily go much further than that. And one of the problems with the sort of British view of just get on with it and don't complain is that often deliverers of service don't actually know it's not going swimmingly well, because no one deliberately goes out to commission a service that doesn't work or isn't fit for purpose or doing its job. But if no one complains, or that there isn't an example of what's wrong with it, it's very difficult to sort of put it right. So, one of the key functions of Healthwatch, in it's sitting in things like the Health and Wellbeing Board, primary commissioning boards, planned care boards, is to actually bring back real experiences. And I think one that really resonated with me was we had lots of people talking to us about problems with getting emergency blood tests last year. In fact, one of the inquiries I actually remember came via our local MP's office with a very panicked resident of West Berkshire. And when I actually took this to planned care, phlebotomy services locally weren't even on the agenda, because they were, like many other services, just trying to manage with what was going on. And by being able to actually bring these experiences back, it became an agenda item, and the professionals and medics actually said, oh yes, we can recognize here there is an issue. We need to start doing something about this to help restore. Now, I'm sure that possibly would have happened anyway, but it really does show that by bringing feedback via ourselves or similar organizations, the statutory bodies really do want to try and do the very best they can for our local residents. So it's really, really important that we do our job successfully in engaging with the public. And equally, we encourage the public all the time to come and tell us the good stuff, absolutely, because we don't get enough of that. People who will complain about bad stuff, but they seldom tell you, do you know, that was brilliant, the service I got at the surgery or the pharmacy or via adult social care was fantastic. But the important thing is that people do tell us, and it's also important that people tell us it doesn't have to be a major complaint. It can just be a grumble, because when you find some of the things that have gone quite badly wrong around the country, it didn't just happen overnight. It was one thing and another, and something else that got missed, and something else that got missed, and somehow it got missed at a quality board or something like this. And all of a sudden, you've got some huge scandal like Morecambe Bay or Shrewsbury or something like this, or Walton Hall, and there are hundreds of people involved, but somehow it still happens. So I did just want to emphasize that, one of the key functions of Healthwatch is A, to make sure we capture the residents of West Berkshire's feedback, but B, we also deliver it in a way that's constructive, useful and helpful to the commissioners, the providers of service. I think the other thing I just briefly wanted to touch on that lots of people aren't really sure about is Healthwatch is one of the few services that does both social care and health. and practically everything in between. So we have an enormous portfolio, and we do have to be very, very careful about what we try and take on and what we don't try and take on. So in terms of the reports we put together, the projects we work on, we do make sure there is clearly something not quite right. So last year we're doing things like maternity. It was clear that there was some gaps, and nationally maternity is now being highlighted as a problem. Dentistry the same, as I said, phlebotomy, really, really important. And then, you know, some of the other positives that are highlighted in the report, where it isn't easy to engage with the public, sometimes we've actually had to go out and create a vehicle. So we've done this with the West Berkshire Diversity Forum, with the West Berkshire Maternity Forum. We're about to launch a CAMS report, which was a survey that ran where we got a pretty good response. And one of the other key things from the pandemic is that health inequalities, and a term I actually prefer, health iniquities, really do have a dramatic effect. And what the pandemic did was it just highlighted this massively. So if people were already suffering from those issues, whatever it happened to be, it tended to make it worse. So having previously talked about the joint health and wellbeing strategy and how that's hoping to make a difference, I think one of the other key things I wanted to underline, and part of the reason we do the annual report and we do some of our other reports, is it's really important the system is open to learning. And I think I put this in the in our COVID report, and it was something I did want the health and scrutiny, the scrutiny board to really pick up on the pandemic and some of our work is, there's little point having gone through things like the pandemic or challenges with service if at the end of the day we aren't capturing some of the learning. And you know, our priorities for next year include things like the recovery of services to pre-COVID levels, as I said, working with the ethnically diverse community, maternity and children's mental health. But I've already started to see a little bit of reversion back to pre-pandemic ways of, well, we had this plan, that's what we're going to do as if the pandemic didn't happen. So we've already found we've got buildings that aren't really fit for purpose if there's a pandemic on. And yet when we're planning new buildings, new hospitals, things like this, we have to really make sure we actually say, well, if that does happen again, how's this going to be placed? So I think that's really all I wanted to say about the annual report, because as I said, we've captured such a huge amount of work, and the challenges we had were clearly not being able to get out there and also not having the public as accessible. Digital exclusion really, really matters. And one of the great pieces of work that's going on now between the council, the CCG and public health is the understanding that just handing a piece of technology to someone is not always the answer. Some people, if you do it, will be straight off and running with it. Some people with some help will be straight off and running with it, but some people will never be able to do it. And if you're going to access services via digital, you have to make sure there is someone stood next to them to actually enable it to happen. We have a heck of a backlog to deal with. We have to make sure that's managed equitably and as quickly as possible, and effectively we don't create new health inequalities by forgetting particular groups, particular conditions, particular, it's interesting, waiting lists that have been throughout the whole press in the last week or two. They're pretty much focusing on physical health waiting lists. There's been very little mention of mental health waiting lists, which, you know, are equal. And we talked about dementia. You know, the dementia diagnosis service runs through the memory clinic. You cannot get a diagnosis for dementia without going to the memory clinic. And from, I think, March to September, the memory clinic was closed. So again, it creates another backlog. But, you know, the dementia diagnosis and the people caring for people with dementia, well, their battle still continued, whether the service was closed or not. So, you know, if things like that do have to happen, we have to be sure that there's mitigations going into place, or when the recovery comes back, we don't just look at people waiting on a bit longer on knee operations, cataract operations, hip operations. It is things like dementia diagnosis. It is things like the CAMS service for children with mental health issues. Yeah, so I didn't really want to talk too much more. Happy to take questions, and hopefully that's detailed enough for all the members here what we sort of do.
Thank you, Andrew. That was really helpful. So
Thank you.
I'll invite questions, and Councillor Linden.
Thank you, Chairman. Yes, on the points you raised, Andrew, obviously a lot of services are still under a lot of pressure because of COVID and people having to isolate and all the rest of it. We may get an improvement on the 16th of August, we may not. So is there anything you want us particularly to assist you with? You may obviously in another forum speak to the Health and Wellbeing Board, the executive member and others. Is there anything you want to raise with us? Because I know you raised a few things at our informal briefing we had with you in formulating health scrutiny again and coming about again. So is there anything you want to add further to that?
I think just briefly, Councillor Linden, I think there is, because I think you've highlighted some interesting things. The chief one for me, and this came out of our COVID report being presented at the Health and Wellbeing, which again, what delighted me was the willingness for partners to listen, to hear when things didn't go quite so well. And what I really was hoping this board, or this committee rather, can capture is how we actually go through capturing the learnings of this. So we don't just having going, oh, well, that was COVID, that's what happened. What we actually do in terms of where we had perhaps planned for pandemics like flu or something like this, well, we've had a different pandemic that hadn't been planned for, and look at the effects it's had. So when and if we're putting policies, strategies, changes to services together, we actually go, well, what did we learn? What didn't work? What was missing? And equally, you know, as did happen in so many different services and certainly from the community, what did work? You know, the community response, the voluntary sector response was nothing short of fabulous. But equally, as you're quite right, with certain services, we've still got major challenges. Dentistry is obviously one we highlighted in our report. We've highlighted it in our annual report as well. It remains, in our opinion, as a national service, not fit for purpose. It is a Cinderella service. It's not understood by professionals. It's not understood by the public. You know, every day people are telling me, well, I can't register with my NHS dentist. Well, you don't need to. The service isn't about registration. The chap who runs it in the Southeast is happy to come and talk to this board or to the Health and Wellbeing Board. And he has said to me, NHS dentistry is a bit like having your hair cut. You find a barber that's got a gap and you go in there and get it done. And yet the public, almost, I would say 95% believe you have to register with a dentist. Oral health is one of the nation's disasters. You know, he will openly admit that 25% of our population don't see any dentist. Now, if it was any other condition, you know, we'd be really tearing our hair out about this sort of thing and saying, well, something must be done. But the positive that is come out of this is that dentistry is going into the new integrated care system management, because one of the problems we've always had as a service was whenever we raised dentistry with a clinical commissioning group, they kind of shrug their shoulders and say, well, we don't commission it. And it actually getting in to see the people who did was sort of akin to finding MI5 agents. They were very, very difficult to get hold of. And you know, and all power to NHS Southeast who've come up and actually met with us and offered to come and speak to people about things like NHS dentistry. So let's please get them in and get and have a chat and see what their suggestions are. But I think really seriously, we've got to look at the new long-term plan with NHS and dentistry and say, as the chief officer for dentistry in the NHS said in a meeting I was in, we have to put the mouth back in the body and not treat it as a separate area or item. Maternity is really key as well. We've got to get that better. And one of the other things I'd like the board to concentrate on, and I noticed it in the work plan, is we have 4 hospitals that serve the residents of West Berkshire, but there is only one that's actually in our ICP and our ICS. So, you know, Hampshire Hospital, we've got to keep that on our radar. Great Western, we've got to keep on our radar. Actually, there's 2, my apologies. John Radcliffe in Oxford is in our ICS, but it's not in our ICP. But we have to always say, when we're talking about a service, be it maternity or something like this, well, what about the people who are using Basingstoke, or what about the people using Great Western? Because otherwise we're doing a disservice to our residents. So sorry if that was a bit longer.
Sorry, Councillor Linder, does that answer your question? Yeah.
Yes, Chairman.
Can I just make a couple of comments before I take further questions? First of all, I am aware that OSMC is doing a piece on COVID learnings. So that probably sort of dovetails in, and you will be pleased to see on the work programme that we do have dentistry, and perhaps we need to move that a bit higher up the list in terms of potential dates. Thank you. Okay, so Councillor Moore.
Thank you, Chair. And Andrew, thank you for your report. One of the things I particularly liked about it was the little anecdotes that you got in there, and it just brought up for me, two or three of them. I think one of my concerns, which is about GP receptionists. I think this is a profession that's under quite a lot of pressure, and I just would, like your observations about it's a profession. They are a triage, and how do they go about it, and where might it improve?
I think one of the other things I've actually forgotten that I should have mentioned, Councillor Linden, is workforce. Every time anyone talks about the health and social care service, they should probably start off with the word workforce and then move on to the next point. It is a major, major challenge in West Berkshire in almost every single service. And receptionists, I would again put under this, because they have an incredibly challenging job. It's a bit like some of our other key workers. It's only seen as key when you really find you need them. They're given conflicting targets from various people. So on one hand, it's, help the patients as much as you can. And then on the other hand, it's, well, the doctors haven't got any time. So if you could just make sure we don't end up with, more appointments than we've got doctors. There's also some bizarre anomalies that you've got to remember. GP surgeries are private businesses. They can all operate in the way they want to. And on one hand, you've got NHS England saying anyone can register with the GP, you don't need ID to go and do it. But then to actually access NHS GP digital services, you need photo ID. And often these two things are getting confused. So, we've heard so many stories of people turning up at GPs, sometimes even with support workers from the council or from voluntary sector services, being turned down flat to register. And we're currently talking to CCG about this problem of how do you access your own digital records if you haven't got a passport or a driving license. And it is a challenge, but I think the key thing for us is we have to recognize that receptionists, like carers and other similar jobs, are absolutely vital, because without them, the GPs couldn't operate. They should be seen as a profession. We should do everything to support training to improve things. And I think equally a shift from almost this sort of managing demand by saying how can we potentially not help someone, to, even if we can't help someone, where can we send them to get some help, even if it isn't the GP? So this whole sort of integration needs to start almost with this frontline person, because no one goes into a GP's receptionist, generally speaking, unless they have a challenge. It just might not be the challenge that a GP is best equipped to handle. So I think by really good integration and better training of people, we can actually make sure everyone leaves knowing they've got a piece of information, they're being sent to the right person, and they're not being frustrated or looked over.
Thank you. Councillor Macro.
Okay. I was quite impressed with the report, and particularly with the various little stories about people being helped, like the couple on the narrowboat who couldn't get temporary registration, for example. And I'm just wondering whether enough is done actually to kind of promote this aspect of your work, and how people actually know that if they have a problem, they can come to you and you might be able to sort it for them.
Well, I think it's really interesting, because if you officially look through our remit, we're meant to capture themes and challenges collectively, but we're one of the few services that talks to every department within health and social care. So actually it's often quite easy for us to say, oh, well, we know who's doing that or how we can unblock that. Our limitation comes from just, we have 2.5 staff full time. We have a huge portfolio. And I think integrating with other services is going to be one of the solutions to this going forward, where perhaps if we can work closer with citizens' advice, with the job centre, with local GP services, with adult social care, although we can help people, but often other voluntary sectors don't have the answers to hand. So, you know, having information easily and readily available, like the West Berkshire directory, some of the work that will come out of joint health and wellbeing strategy. We talk about self-care, which is going to be really important for our populations, but we've got to make it easy for people to be able to find solutions themselves, so that potentially the people who might be digitally excluded can still turn up at a service, can still get through on a telephone line, because they have no other means of doing it. So I'm really proud of us being able to solve what often I colloquially term daft things. So, you know, being told to go back 300 miles via a narrowboat to get your vaccination because that's where your GP is. You know, that wasn't actually a difficult one to solve, but it was really, really important to that couple because they were really stressed by it. But it does sort of prove that, you know, if you do know who to go to and who might be able to solve the problem, things can get sorted. But I think the process, that's one of the sort of COVID learnings of the sort of, we've got it for 90% of the people, but we haven't really considered the other 10% who might be in the wrong place, who might not have the documents, you know, because we had a challenge with getting the homeless people vaccinated, and it was really down to, you know, one fabulously brave GP from Wokingham who basically turned up and did some work with the soup kitchen. All power to them. Whereas, you know, officially, the powers that be were saying, oh, you really shouldn't jab them yet. And yet 2 weeks later, it was, no, you really should. So, yes, I think if we could broadcast what we do more widely and more people would know about us, then I'd love that to happen. And I think one of the things I'm hoping we can do, which we've discussed at Health and Wellbeing, is using things like the council's excellent communications package for voluntary sector partners like ourselves, to be able to get messages across and things like this. So I think, you know, one of the things I'd say to both health partners and statutory partners is there a gap for someone from your voluntary sector? So if you are putting newsletters out, if you are writing to everybody, is there a gap where you could put some information out about us, about another voluntary sector service that might have relevance? Because there might be someone reading it or seeing it who just might not know or might not have heard about you, and it might help make a difference.
Actually, just Andrew, just on that point, it might be worth looking at ways in which we can work together to leverage some of our relationships. So, for example, I'm the local authority representative on the CAB. So perhaps that's a, you know, way of trying to connect, you know, the two organisations in a clever way. So we should probably take that offline and discuss that, and other partnerships that we have, I think would be helpful.
I think that's a really good idea. Thank you.
Are there any other questions? I just wanted, no other questions? No. So I just want to say, Andrew, thank you so much for sharing the report. I read it with great interest, and obviously you are hopefully going to be a standing agenda item moving forward. I think we're very keen to work closely with you. You are at the coalface. You do have the public voice, and I think personally as chairman, I'm quite keen to get the public voice into this committee so that we really hear from the front line. And so if there are, I know you're going to be referring matters to us, and if there's anything you think we should be particularly prioritising and focusing on, I think members would welcome that. So thank you very much.
Thank you.
Okay, moving on to the final agenda item, work programme. So hopefully you've all had a chance to have a look at the work programme, and really it's to ask you to note it, but also to highlight that we are going to have a series of informal briefings, and just to make people aware that the reasoning behind that was really as a new committee, and with the vast sea of the NHS acronyms and jargon and different bodies and sort of how they all fit together, which I think we've all sort of discussed in terms of how challenging that is. We thought it would be good to have some informal sessions just to get the committee up to speed so that we don't waste too much time in the committee actually doing that. And whilst very much welcome Andrew Sharp's background to Healthwatch, which was incredibly helpful, I think it was where we have other organisations that we're going to be engaging with. It's probably just to cut through some of that time and sort of to help the understanding of the members. But really, yeah, just to invite any comments, and if anybody's got any other further suggestions for the work programme. Councillor Linden.
Yes, thank you, Chairman. I wrote a couple of things with you prior to the meeting. On page 122, we've got the Royal Berkshire NHS Foundation Trust. I know we did mention informally that currently they like to deal with Reading Borough because that's where they're based. But I think it is equally well important that they also deal with the other two local authorities, ourselves and Woking Borough. I just want to put that on record because we have discussed it in our informal meeting. And previously, when I was chairman of Health Scrutiny, we did have an excellent contact with them. So it's no real excuse. We do need to have that full contact because we're an important body. And also as a council as well, and health and wellbeing. The other point, just mentioning, because the chairman suggested I mention it, I'm going to be a vaccine volunteer helping out at Calcott on Sunday morning. So I thought I'd put my name forward for that, and they've accepted me. So I'll just wait and see what I'm asked to do. But the volunteers have done a fantastic job. I know when I had my 2 jabs, they're very helpful, very friendly, and they really made a difference, those volunteers. And some of the weather conditions was bloody awful. I mean, now it's summer, so it's much better. Thank you, Chairman.
Thank you. Councillor Moore.
Thank you, Chair. Yeah, actually, just noticing the informal briefings, I think there's been a cut and paste or copy and paste job. So the Healthcare NHS Foundation Trust, the purpose is the same text as the box above it. I imagine it's probably not a lot different, in fact, but it'd be interesting to know what the subtle difference there is. My more substantive question was really the protocol item on the things that we've got to the forward plan, and it was just to get a bit of a feel as to how many protocols we might be wrestling with in due course. Perhaps Gordon can help us on that.
Any comment from Mr. Oliver?
Yeah, I mean, this is just setting out a protocol just so it sets out just a way of working between us and the other health partners, just to sort of say what the various responsibilities are, and in the event of a disagreement, how that would be managed. So it's just really just setting out a rule book, if you like, that all parties should hopefully work to. So I'm hoping we won't have more than one of those protocols.
Oh, so all sign up to the basic one text, as it were. Okay, thank you.
Thank you. Councillor Macro.
Thank you. It's a couple of ideas for the kind of work programme. One is, I think we ought to be looking at mental health for young people before very long, because that shone through on the Healthwatch report. The number of people who said, I can't get help, I've been self-harming and suicides and all kinds of horrible things. And the other thing is continual continued healthcare funding, which has long been a thorn in the side of certainly this council. And I believe we're down at, if we're not right at the bottom of level of funding, we're very close to the bottom.
Thank you, Councillor Macro. Andrew.
Yeah, just with a reference to what I made before, that I know from the chief executive of Hampshire Hospital, they are very, very keen to have much better and closer relationships with West Berkshire. So I think in the same way we've got both Royal Berkshire and Berkshire Healthcare potentially as work streams, I think we should add Hampshire Hospitals and Great Western certainly as the sort of two really key other hospital trusts. Both we have excellent relations with, both I know would be very keen to potentially come and talk to the board. And of course, one of the key things that possibly the board might want to think about is the HIP2 projects, both with Royal Berks and Basingstoke, where potentially either rebuilt or certainly in Basingstoke Hospital's case, there almost certainly will be a new hospital. So in terms of how that's planned and put forward and put together, I'm not sure if this is the right place, but it's just something I think the board should be mindful of. And the same with mentioning the ambulance service, which I think was possibly left off there, that from time to time you might want to get an update from them and the out of hours GP service.
Thank you. Councillor Bridgman.
Thank you, Chairman. If I can pick up the last point first.
We can hear you now. It's just the first bit.
If I can pick up the last point first, I had a discussion with Gordon, I think with you as well.
We've lost your sound.
I do apologise.
That's better.
What's going on with these headphones on this particular laptop?
No. We can hear you in and out.
What shall I do? Shall I?
That's good.
I'll try. Look, just shout this first up. On the last point, I had the conversation with you and with Gordon, I think, about where this lies, and it doesn't lie with this committee, unfortunately. I suggested it. The two building projects are effectively, because they're cross-border, they need to be joint health overviews, and indeed there is a joint. We assigned members to joint health overview and scrutiny across Bob, and I think that's where this one will lie. So that's the point on the rebuilding programs, both for Hampshire and for Royal Berks. On the Royal Berks point, as raised by Councillor Linden, simply to say we have a new, has yet to be finalised, but new representative Royal Berks coming onto Health and Wellbeing Board. And indeed, there will be a presentation by Dom Hardy, we hope, at the next Health and Wellbeing Board on certain aspects of the ICP piece. So I hope that the conversation with Royal Berks, and if I can help as a governor, I'm very happy to push things in that direction, to have a conversation with you as you think it needs to happen. Finally, on CHC, I note that you have a standing item on the forward plan for conversation with the CCG, and I would suggest that continuing healthcare, and I can assure everyone I am as interested, both with my current hat and with my previous hat on, as Councillor Macro is, in upping our game on CHC, is part of that standing item. Thank you, Chair.
Thank you, Councillor Bridgman. Very helpful. Andrew.
Yeah, just on the CHC front, funnily enough, the joint health watchers across Bob are actually having a conversation about continuing healthcare, because if I remember rightly from my facts, Berkshire West is actually at the bottom, if not at the bottom of the whole country. And just to give you a comparison, I think it's 13 cases per 100,000 get CHC in Berkshire West, but in Buckinghamshire it's 56 cases per 100,000, and in Cumbria it's 108. So just within Bob they have quite a big disparity, and as I know from someone I know very, very well, the struggle it puts on people going through is just tremendous, because, you know, certainly if it's family members or stuff like this, they are at the very worst part of their journey, being asked to go through a really tricky process. And I just think there's too many cases where the pressure put on them is just not fair. And there does seem to be almost a sort of, how can we go about not letting this happen, even to people who desperately need it? So yeah, I equally would like to see that as a pretty serious and urgent item, if at all possible. Thank you.
Thank you. Any other comments on the work programme or thoughts?
My
Yeah,
apologies.
Andrew.
Yes, the closing of the Duchess of Kent Hospice, which I'm not sure if everyone has heard or come across. So the service is quite dramatically being closed off. So hospice care has always been an interesting topic in West Berkshire, but may become more so. So I'm wondering whether that should potentially feature somewhere. So although the CCG, I believe, have put in some intermediate mitigation, there is that sort of longer term picture of, well, what should happen and where should that service be supported? And there is talk about the sort of hospice at home service, but as we've often found with even a previous service called hospital at home, it didn't desperately work that well. And also often patients prefer a more formal environment where they feel there is a greater degree of help or whatever, because we have had to put off our conversation about dying matters and things like this because of the pandemic. We think, again, it's something we really should do as soon as we possibly can, because it's important that people do consider how when they come to that point in their life, how they'd like things to happen. So having that happen with the hospice, I'm sorry, I just forgot, is something I think members should probably consider in the relatively near future.
Thank you. And actually, it's an interesting point, because I wonder if the demand for that may go up as you see the impact of COVID, where we haven't been able to treat people as quickly, for other things such as cancer, that we may see that increase. I think it's a really, really valid point. Thank you, Andrew, for raising that. Okay, no other comments. So that draws business to a conclude. I'd like to thank everyone for attending this afternoon. And that concludes the meeting. I'd like to also just ask all panelists virtually if you could remain in the virtual room until the Zoom host has confirmed that the meeting is no longer live streamed.